Welcome to the deep dive. Our mission today is to cut through the noise and provide you with a comprehensive masterclass on a foundational public health issue, sexually transmitted infections and HIV. We've synthesized massive clinical sources, and we are going beyond the headlines to understand the true mechanics, the long-term consequences, and the critical management protocols.
Right.
If you need to be an expert in this field, well, this is your crash course.
That's right. And we should probably start with the fundamentals. Look, while many people still use the term STDs, sexually transmitted diseases, our sources really emphasize the contemporary clinical standard, STIs, or sexually transmitted infections.
Okay.
Basically, these are clinical syndromes caused by pathogens acquired and transmitted through sexual activity.
And what makes this a global threat? The scale.
Exactly. It's the scale, the increasing incidence. It's driven, according to the research, by, well, promiscuity and frequent changes in partners, really a volume problem.
Yeah.
And clinically speaking, infections located in the lower genital tract, they are consistently among the most common complaints seen by gynecologists worldwide. Yeah. Just constantly coming up.
Okay, let's unpack the stakes here because we're not just talking about minor discomfort, are we? The consequences of these lower tract infections can truly derail a person's reproductive health and, well, their overall lifespan.
Oh, they absolutely can be life-altering. The primary concern really is the risk of ascending infection.
So moving upwards.
Exactly. When pathogens move up from the cervix and vagina, they can cause pelvic inflammatory disease, or PID.
PID, okay.
And if those fallopian tubes become involved, if they get scarred, the patient faces really high risks of irreversible infertility or even a life-threatening ectopic pregnancy.
Wow, that's the structural damage then.
That's the structural side. Then you've got the biological threat. Specifically, certain viral infections like human papillomavirus, HPV, are notorious for their link to vulval and cervical cancers.
Right.
So the infection can go from being an annoyance to a systemic oncological risk factor. It's a big leap.
And the risk extends directly into family planning, too. If an infected mother becomes pregnant, the consequences for the fetus, they can be severe.
Absolutely. We see a whole cluster of potential obstetric complications, repeated pregnancy losses, intrauterine fetal death, and problems for the newborn itself. Things like severe eye and throat infections, even systemic septicemia. Furthermore, some of the most, dangerous infections, like syphilis and HIV, they're known for vertical transmission.
Meaning mother to child.
Yes, passing from mother to child either during gestation or delivery. However, and this is crucial, the sources offer a powerful intervention point here. Routine antenatal screening and prompt aggressive treatment can drastically reduce or even eliminate this vertical risk.
So it turns a potential tragedy into something manageable.
Exactly. It turns a tragic inevitability into a manageable condition, which is huge progress.
That distinction between the untreated risk and the managed outcome is absolutely vital. Before we dive into specific diseases, let's maybe look at the sheer numbers for the most common vaginal complaints. The big three that seem to drive most patient visits.
Yeah, that's a good idea. When you analyze the prevalence of vaginitis, there's a pretty clear hierarchy. Bacterial vaginosis, or BV, accounts for the biggest chunk of cases, typically around 40% to 50%.
Okay, BV first.
Right. And that's essentially an imbalance of the normal vaginal flora. Second is manilial, or fungal, infection, primarily Candida albicans. That's responsible for maybe 20% to 25% of cases.
Indeed, you're right.
And finally, trichomonas, which is a protozoal infection, accounts for about 15% to 20%.
So those three dominate.
They do dominate, but the sources stress we cannot ignore the growing prevalence of chlamydial infection. It's often silent, but carries devastating long-term risks, which we'll definitely cover in more detail later.
Okay. And while the primary route for all these is obviously sexual contact, our sources remind us that for some pathogens, especially the ones that become systemic, other transmission pathways exist, right?
They do, and understanding these pathways is really key to mastery. For systemic diseases like syphilis, HIV, and hepatitis B, the pathogens can spread through, say, unscreened blood transfusions or shared infected needles.
Which is relevant for IV drug users or maybe unsafe healthcare settings.
Precisely. Highly relevant in those contexts. It's worth noting, though, the sources specifically categorize transmission via fomites like sharing toilets or towels as, rare causes.
So not impossible, but unlikely.
Right. Often requires specific circumstances like a highly altered vaginal pH, but they are technically possible routes for some organisms like Trichomonas.
Okay, that provides our essential context. Let's now move to sort of the front line of defense, The vulva and the common infections and even infestations that start right there.
Right, the vulva.
Yeah.
It's essentially specialized external skin and mucous membrane. It's made up of stratified squamous epithelium, which is just tough, multi-layered skin, along with oil glands, sweat glands, the specialized Bartholin's glands.
And common symptoms presenting there.
For patients coming into the clinic, vulvar itching or pruritus and burning are incredibly common. They account for maybe 10 to 15% of all gynecological complaints.
And one of the most, well, memorable causes of that intense, almost unbearable itching is a parasitic infestation, the crab louse, leading to pediculosis pubis.
Yes, virus pubis. This one is highly contagious, making it a classic STD. Transmission is usually intimate contact, but the sources confirm it can also spread via shared bedding or towels.
How does it work?
Well, the louse is basically a tiny blood-feeding parasite. It deposits its eggs, the nits, directly at the base of the hair follicles. Clinically, the main feature is just excruciating pruritus in the pubic area.
So intense, it causes other problems.
Yeah, it can be so that it leads to insomnia, significant irritation, and, real social distress for the patient.
What's the gold standard treatment look like? And I believe there's a critical cautionary note for certain people.
Treatment is topical. Permethrin cream, 5% is standard. Often needs 2 applications, about 10 days apart.
Why 2?
To catch any eggs, any nits that hatch after the first application kills the live lice. Alternatively, gamma-benzene hexchloride 1% lotion or shampoo is used.
Okay. And the warning.
The crucial warning here, and this is a real mastery detail, is that these treatments, especially gamma-benzene hexachloride, are contraindicated, meaning absolutely shouldn't be used in pregnant and nursing mothers.
Why is that?
Because of the potential for systemic absorption and toxicity to the fetus or the infant. It's just too risky.
Got it. Okay, next up, scabies caused by the itch mite. How do we distinguish the clinical picture of scabies from the crab louse infestation? They both cause itching, right?
They both cause intense itching, yes. Scabies, transmitted by the itch mite, requires close contact or fomites like shared items. While it often affects flexure surfaces like the inside of elbows, wrists, buttocks, it also commonly involves the external genitalia.
And what's the mite actually doing?
The adult female mite is the culprit. She actually burrows beneath the skin surface to lay her eggs.
Oof.
Yeah. And the key clinical distinction from lice is often the timing of the itch. Scabies causes intense burning and itching that is characteristically more severe at night.
Worse at night.
Often disturbing sleep significantly. When examining, we look for papules, vesicles, or sometimes you can even see the small visible burrows the mite makes.
And the management strategy, similar to pediculosis.
Yes, very similar in principle. Permethrin cream 5% is the backbone again, usually applied over the entire skin surface, typically twice a day for 2 days, or sometimes as a 12-hour lotion application.
Does the itching stop right away?
Not always, because the itching can actually persist even after the mite is killed. It's like a reaction to the dead mite. Materially, antihistamines are often used to control the pruritus.
Right.
And again, same caution. Due to potential systemic absorption, these topical treatments are generally withheld during pregnancy and lactation.
Okay, let's transition from parasites now to a very distinct viral infection, molluscum contagiosum. You mentioned if you see this, the diagnosis should be almost immediate.
It really should. Molluscum is a benign infection caused by a pox virus. It's spread through close contact, sexual or non-sexual, and even through autoinoculation.
Meaning scratching and spreading it yourself.
Exactly. A person scratches one lesion and transfers the virus elsewhere on their own body. It has a fairly long incubation period, sometimes weeks, even months.
And the lesions themselves, what's the giveaway?
The lesions are the clinical tell. They're small, domed, pearly vesicles, usually only 1 to 5 millimeters across. But the defining feature is a central umbilication.
Umbilication, like a little dimple.
Exactly, like a small indentation or crater right at the center of the dome. Very characteristic.
What's inside that central core, and how does that help confirm the diagnosis?
Inside is a white, waxy, sort of cheesy material. If you carefully express or scrape that material and stain it using GYNAECOLOGY stain, you can definitively confirm the diagnosis by seeing these pathognomonic intracytoplasmic molluscum bodies.
Specific inclusion bodies, then.
Right. Large inclusion bodies within the epithelial cells. Treatment basically focuses on physically removing that central core.
How's that done?
It can be done by simple evacuation, excision with a dermal curette, and then chemically treating the base with something like Monsel's solution, which is ferric subsulfate, or maybe 85% trichloroacetic acid to stop bleeding and kill remaining virus.
Are there other methods?
Yes, destructive methods like cryotherapy, freezing, or electrocoagulation burning are also effective alternatives.
Okay. We now move into, I think, a really critical domain,
Yeah.
genital ulcers and the high-risk viral infections, starting with condylomata, acuminata, or venereal warts. This is where we really start to grasp the systemic and long-term danger of HPV. Right.
HPV is, without question, one of the most critical pathogens in this whole deep dive. It's a small, double-stranded DNA virus, and it's epitheliotropic.
Meaning it targets skin cells.
Specifically epithelial tissue, yes. Skin and mucous membranes. The clinical manifestation everyone recognizes is the verrucous or warty growth. These can be small and discrete, or they can merge together, coalesce, to form these large, distinctive, cauliflower-like growths.
Where do they typically show up?
Frequently found on the labia majora, the perineum, the vagina, and also the perianal region.
Now, mastering HPV requires understanding the different types and their implications you have to separate the sort of nuisance types from the really dangerous ones.
Precisely.
Yeah.
We categorize them based on their oncological risk, their cancer-causing potential. HPV types 6 and 11 are considered low risk. They're the ones primarily responsible for the physical condyloma acuminatum itself, the visible warts.
Okay, 6 and 11 cause the warts.
Right. But the high-risk types, especially 16 and 18, but also others like 31, 32, and 33, those are the ones strongly implicated in cancers of the cervix and vulva.
And the statistic here is really shocking.
It is staggering. Our sources indicate that HPV contributes to a massive 15% of all cancers globally.
15%.
15%. And cervical cancer accounts for about 80% of those HPV-related cancers. So this is not just some localized skin infection. It's a major systemic oncology driver.
Wow. To put that 15% statistic into perspective, a single type of STD is linked to nearly 1 in 6 cancers worldwide. That elevates this topic far beyond just gynecology.
It really does. And histologically, when you look under the microscope to confirm an HPV infection or a precancerous lesion, it relies on recognizing specific cellular changes. The definitive marker is the presence of coilocytes.
Coilocytes. What do they look like?
They're cells that look kind of puffy and abnormal. The HPV virus basically pushes the cell's nucleus off to the side, creating this clear, dramatic halo around it. A paranuclear halo.
Very distinct.
Very distinct. Other signs include cells with multiple nuclei or multinucleation, and just general tissue thickening, which we call acanthosis, plus signs of chronic inflammation.
So what happens once a young woman acquires HPV? What's the natural, unmanaged history? Does it always lead to problems?
Thankfully, no. And this is where we see the body's natural protective mechanism often work quite well. In young, otherwise healthy women, the infection is often transient.
Meaning it goes away on its own?
Yes. About 90% of cases will spontaneously clear the virus without causing any permanent DNA alteration. This clearance typically happens within about 2 years.
But not always.
Not always. In older women, or critically, in immunocompromised individuals like those with HIV, for instance, the infection often persists. And when it persists, that's the danger zone. Up to 30% of those persistent cases can progress to carcinoma in situ.
Which is precancer.
Exactly, a precancerous stage within just 1 to 3 years. And that can eventually lead to full-blown invasive cancer of the cervix or vulva.
Given that very real risk, diagnosis requires extreme vigilance. How do clinicians make sure they detect not just the wart itself, but any potential underlying malignancy?
The diagnosis has to be multi-layered. For the cervix, a colposcopic study is performed. That's using a magnifying scope. It's often aided by applying acetic acid, basically vinegar, which turns precancerous or abnormal areas white, making them easier to see.
And for vulval lesions?
For vulval lesions, a 1% toluidine blue staining technique can be used. Abnormal dysplastic nuclei in the cells retain the blue dye, highlighting areas where a mandatory biopsy is needed to definitively rule out malignancy.
Biopsy is key.
Biopsy is mandatory if there's any suspicion. And of course, a standard pap smear is also essential to screen for any cervical changes concurrently.
Okay. Regarding treatment for the warts themselves, you mentioned a range from just watching them to, well, highly targeted destruction.
Correct. Sometimes we might just observe flat condyloma in young women, especially during pregnancy, because of that high chance of spontaneous regression, maybe within 6 months.
But if they persist or are bothersome...
Then for active lesions, local destruction is necessary. We can use topical agents like podophyllin. It's usually a 20% to 25% concentration in alcohol or tincture of benzoin. Or we might use a combination of 25% trichloroacetic acid plus 5% fluorosil.
And how do those work?
These chemicals essentially cause the warts to necrose and slough off, usually within 3 to 4 days. They have pretty high success rates. Around 70% of cases respond well.
Now, speaking of treatment, I know podophyllin is common for warts, but our sources flag a major danger point, especially in pregnancy. What is the essential warning here?
Yes, this is absolutely critical. The warning is absolute. Podophyllin is strictly contraindicated in the first trimester of pregnancy
Why?
because it can be absorbed systemically into the bloodstream, and it's cytotoxic.
Yeah.
It damages cells. This means it carries a real risk of causing abortion or even peripheral neuropathy in the developing fetus.
So it's dangerous systemically, even though it works locally.
Precisely. That cytotoxic effect is why we use it on the lesion, but it makes it dangerous if absorbed systemically during early pregnancy. In pregnant patients, we have to use safer alternatives like trichloroacetic acid or physical removal methods.
And if those warts are large or near the birth canal when it's time for delivery?
Yet, if large vulval or vaginal warts are present when labor is due, a cesarean section may be required.
Why a C-section?
This is to avoid a rare but potentially severe complication in the newborn known as neonatal laryngeal papillomatosis. This happens if the infant aspirates infected tissue during vaginal passage, leading to warts in their airway.
Wow. Okay, so ultimately prevention seems like the key to mastering HPV, which leads us directly to the prophylactic vaccines.
This really is the triumph of modern medicine in this particular space. We have the bivalent vaccine, Cervarix, which targets the two highest risk types, 16 and 18. We have the quadrivalent vaccine, Gardasil or Silgard, which targets those two, plus the two main wart-causing types, 6 and 11.
And the timing is crucial.
The core principle of vaccination is timing. It absolutely must be administered before exposure to sexual activity, ideally in early adolescence, to confer maximum protection. The schedules usually involve 2 or 3 doses given over about 6 months.
Are there other preventative measures besides the vaccine?
Yes, generally supporting cellular immunity is helpful. Things like adequate vitamin C and folic acid intake, and critically strict avoidance of smoking is also recommended, as smoking is a well-known cofactor in cervical cancer progression alongside HPV.
Okay. Shifting now to our second major viral threat, genital herpes simplex virus, or HSV, often called the recurrent ulcer. This one really defines the frustration of an infection that we can't fully eradicate.
It absolutely does. HSV, primarily type 2 in the genital area, is a double-stranded DNA virus that has unfortunately reached epidemic proportions, particularly in developed countries. It causes about 80% of vulval herpes infections.
And the incubation.
Typically short, usually around 3 to 7 days after exposure.
Can you trace the clinical course for us, starting with the very first, the primary infection?
Right. The primary infection is usually the worst episode the person will experience. Patients often present with constitutional symptoms, first feeling generally unwell, malaise, headache, maybe a fever, alongside a very specific vulval paresthesia.
Paresthesia.
Like tingling.
Exactly. That tingling, burning, or itching sensation in the area where the outbreak is about to occur. This is then followed by crops of shallow, very painful vesicles, little blisters, and ulcers that often merge together.
How long does that last?
The outbreak itself is self-limited, usually resolving in about 2 weeks, and importantly, it typically heals without leaving any scarring. However, viral shedding, the period when the patient is most contagious, can actually continue for several weeks after the lesions have healed.
And the reason it keeps coming back, the recurrent nature. Where exactly does this virus hide out between outbreaks?
This is the key. The virus cannot be cleared by the immune system or current drugs. It retreats and becomes latent. It literally travels up the sensory nerves from the site of infection and takes up residence in the dorsal root ganglia.
Nerve clusters near the spine.
Exactly. Specifically in the S2, S3, and S4 nerves that supply the pelvic area. This protected location within the nervous system makes it impossible for the immune system or medications to eradicate it completely.
So it just waits there.
It just waits there. And it gets reactivated periodically, especially when the patient is under stress, ill, or immunocompromised, which is why recurrences are so common and can even be triggered during pregnancy when the immune system is naturally modulated.
How do those recurrent episodes typically differ from the initial primary attack?
Thankfully, recurrences are usually significantly milder and shorter in duration, often lasting less than a week. Those systemic symptoms like fever and malaise are typically absent.
But the warning signs are similar.
Yes, they are often preceded by those same prodromal symptoms that localize burning, itching, or tingling sensation where the lesions will appear. Statistically, about half of those infected experience their first recurrence within 6 months of the primary infection, and on average, women might suffer about 4 recurrences in that first year.
Okay, so if eradication is impossible, what are the main goals of management according to guidelines like the CDC's?
The goals have to be pragmatic. We aim to shorten the duration and reduce the severity of each outbreak, prevent complications like secondary bacterial infection, and crucially, reduce the risk of transmission to partners.
And counseling is key there.
Absolutely essential. Since viral shedding continues even when lesions look healed, a crucial counseling point is complete abstinence from intercourse, starting from the very first prodromal symptom until the skin has completely re-epithelialized and healed over.
Anything else important for counseling?
Yes, we also counsel patients that having active herpes lesions makes them biologically more susceptible to acquiring HIV and other STDs because the broken skin provides an easier entry point.
So what medications do we use?
We rely on antiviral drugs, specifically acyclovir, valacyclovir, or famciclovir, to inhibit viral replication. For a primary infection, for example, acyclovir might be given at 400 milligrams 3 times daily for 7 to 10 days.
And these drugs cure it?
No, and that's the critical point we must make clear to patients. These drugs effectively reduce the severity and duration of the current attack, and suppressive therapy can reduce the frequency of recurrences, but they do not prevent latency or eliminate the virus from the body. They don't cure it.
What about during pregnancy and delivery?
If a patient has active genital lesions near their due date, a cesarean section is strongly recommended, even mandatory in many protocols, to prevent transmission to the newborn during vaginal delivery. Neonatal herpes can be devastating, even fatal.
Right. Okay. Let's transition now to a series of important genital ulcerations that are purely bacterial in origin, starting with granuloma inguinale, also known as donovanosis.
Yes, granuloma inguinale. This is a chronic progressive infection caused by Calamidobacterium granulomatis, which is a gram-negative bacillus. It's more common in tropical and subtropical regions.
And its clinical presentation is quite unique, isn't it?
It is very distinctive. It typically starts as a painless nodule that slowly ulcerates. It leads to multiple, characteristic, beefy red, painless ulcers. These ulcers tend to grow, merge together, and can progressively destroy large areas of the vulva over time.
Painless is key here.
Painless is a key feature.
Yeah.
And another distinguishing feature is that there's usually minimal, if any, significant lymph node swelling, or adenopathy, unlike some other ulcerating diseases.
And the diagnostic confirmation offers a fantastic visual marker under the microscope.
It does indeed. Diagnosis relies on finding the pathognomonic intracytoplasmic donovan bodies. These are essentially clusters of the bacteria visible within the cytoplasm of mononuclear cells, often described as having a classic bipolar or safety pin appearance when stained properly.
Very specific. And treatment?
Treatment requires a lengthy, sustained course of antibiotics. Something like azithromycin, maybe 1 gram weekly or 500 milligrams daily, for at least 3 weeks and often longer, until the lesions are completely healed. Doxycycline is a common alternative if azithromycin isn't suitable. Persistence is key.
Okay. Contrasting that, let's look at lymphogranuloma venereum, or LGV. This is caused by specific, more aggressive serotypes of Chlamydia trachomatis. And here, the initial ulcer is often barely noticeable, right?
That's precisely the danger of LGV. It's caused by the L serotypes L1, L2, and L3 of C. trachomatis. These are different from the strains causing common chlamydia. LGV is highly prevalent in parts of Africa and Asia. And yes, the initial lesion is typically a small, painless vesiculofuscular eruption that heals spontaneously within days. It's very easily missed by the patient.
So the real pathology shows up later, and it's all about the lymphatic system.
Exactly. The problem manifests weeks later, entirely within the lymphatic drainage system.
Which results in the classic complication LGV is known for, the bubo.
Precisely. The organism drains into the pararectal, inguinal, and pelvic lymph nodes. This leads to massive, painful swelling and inflammation, often forming abscesses within the nodes. This large, swollen lymph node mass is called a bubo.
And these can rupture.
Yes, these buboes can become so large and inflamed that they actually adhere to the overlying skin and can burst through it, draining pus. For women, because of the anatomy, contiguous spread from the pararectal lymph nodes is common, often causing proctocolitis, that's inflammation of the rectum and colon, and, worryingly, the formation of devastating rectal strictures over time.
So the long-term consequences here are really due to the scarring and the lymphatic blockage, aren't they?
They are entirely due to the inflammatory response and subsequent scar tissue formation. The resulting scarring can cause severe, debilitating problems. Chronic proctitis, stricture formation that can become severe enough to cause intestinal obstruction, the formation of rectovaginal fistulae, abnormal connections between the rectum and vagina, and there's even a heightened long-term risk of developing vulvar cancer in the damaged tissues.
That sounds incredibly severe. How is it treated?
Because of this potential for severe sequelae, a full, prolonged course of antibiotics is essential. The standard is doxycycline 100 milligrams orally twice a day for a full 21 days. Erythromycin base is the alternative if doxycycline is contraindicated, for example, in pregnancy.
Okay. Our last bacterial ulceration is chancroid, sometimes called soft sore. The name itself implies its clinical hallmark, which is pain.
Yes, chancroid, caused by Haemophilus ducreyi, which is a small gram-negative bacillus and anaerobe. It's common in many underdeveloped countries and affects males maybe 5 to 10 times more often than females. Importantly, like herpes, chancroid ulcers facilitate the spread of HIV.
How does it get in?
It's highly contagious but actually requires broken or traumatized skin to establish infection. The incubation period is short, usually 3 to 6 days.
So how does the chancroid ulcer clinically differ from the other two major types we discussed, the painless syphilis chancre and the painless donovenosis ulcer?
The absolute hallmark is acute, severe pain. It starts as a papule, but progresses rapidly into a painful pustule that then ulcerates. The resulting ulcers are typically shallow, have ragged, undermined edges, and are extremely tender to the touch. This is the complete opposite of the firm, punched-out, painless ulcer of primary syphilis.
Any other features?
Yes, about half of the cases develop unilateral, tender, inguinal lymphadenopathy, swollen, painful lymph nodes in the groin on one side. The lesions themselves are usually sharply demarcated, but lack the firmness, the induration, seen in a syphilis chancre.
And diagnosis?
Diagnosis often involves gram staining of the discharge from the ulcer base or aspirate from a swollen lymph node. If successful, it shows the typical extracellular bacteria clustered together in chains or clumps, classically described as having a school of fish appearance. Culture is possible but difficult.
Treatment, given it's common in resource-limited settings.
Treatment often utilizes single-dose regimens, partly recognizing the challenges of ensuring patient follow-up in high-prevalence areas. Options include azithromycin 1.0 gram orally as a single dose, or ceftriaxone 250 milligram intramuscularly as a single dose. Multi-take courses of erythromycin or ciprofloxacin are alternatives.
And screening is important.
Absolutely essential. Since co-infection with syphilis or herpes is very common, screening for those other STDs is mandatory in anyone diagnosed with chancroid.
Okay. We shift gears now to focus on systemic infections and those that cause massive damage, primarily through ascending infections, starting with perhaps the most infamous bacterial STI, syphilis the great mimicker.
Yes, syphilis, caused by Treponema pallidum, which is a highly motile spirochet. It's spread through direct contact with an infectious lesion, usually requiring broken skin or intact mucous membrane for entry. And it earns its nickname, the Great Mimicker, because its symptoms change so dramatically across its different stages, and it can affect virtually every organ system in the body.
Let's define those stages clearly, starting with primary syphilis. When does that appear?
Primary syphilis typically occurs anywhere between 9 and 90 days after the initial exposure. The characteristic lesion is the chanter.
Describe the chancre again. How is it different from chancroid?
The classic chancre is typically a single, painless, firm ulcer. It has a clean, punched-out looking base and distinct, rolled-out, indurated, hardened edges. Completely different feel and appearance from the soft, painful, ragged ulcer of chancroid.
And it goes away on its own.
Crucially, yes. It heals entirely spontaneously, usually within 3 to 9 weeks, even if the person receives no treatment at all. This healing is often accompanied by firm, painless swelling of the regional lymph nodes, usually the inguinal nodes.
What about testing at this stage?
This is a key diagnostic point. The standard VDRL serological test, which looks for antibodies, is often negative when the chancre first appears. It typically takes 1 to 4 weeks after the chancre develops for the VDRL to become positive.
So you can't rely on blood tests right away?
Not for immediate diagnosis of primary syphilis, no.
Okay, then the secondary stage is when the disease really goes systemic, right?
Yeah, exactly. Secondary syphilis represents the dissemination phase, when the spirochetes spread throughout the bloodstream. This usually occurs 2 to 6 weeks after the primary chancre heals, though sometimes it can overlap. Patients often feel acutely ill with systemic symptoms, malaise, headache, low-grade fever.
And the visible signs?
The key clinical finding is often a generalized, symmetric, asymptomatic maculopapular rash. It doesn't usually itch. Classically, this rash appears on the palms of the hands and the soles of the feet, which is quite specific for secondary syphilis.
Anything else?
Yes. On the vulva or perianal area or other moist areas like under the breasts, patients may develop condylomata lata. These are different from HPV warts, Condylomata acuminata. Condylomata lata are broad, moist, flattened, grayish-white raised lesions that are teeming with spirochetes and are highly contagious.
How long does this stage last?
This secondary stage eventually resolves on its own too, usually after 2 to 6 weeks. And the disease then passes into latent syphilis, which can last for many years, even decades, without any outward signs.
And the final, potentially catastrophic stage, tertiary syphilis.
Tertiary syphilis develops in about a third of untreated individuals, typically 5 to 20 years, sometimes longer, after the initial infection. This is where the severe irreversible organ damage occurs.
What kind of damage?
It manifests in several forms. Neurosyphilis, affecting the brain and spinal cord, leading to conditions like meningitis, stroke, dementia, or tabes dorsalis, a degenerative nerve condition. Cardiosyphilis, causing inflammation of the aorta, aortitis, aortic valve disease, or aneurysms. And gummas, which are destructive, rubbery lesions that can occur in the skin, bones, liver, or other organs.
And the impact on pregnancy is devastating.
In pregnancy, untreated syphilis is terrifying. It can cause late abortion, stillbirth, or severe congenital syphilis in the newborn, leading to profound long-term disability or death.
So diagnosis is critical throughout. How is it confirmed?
Diagnosis requires a dual approach, depending on the stage. For primary and secondary lesions, where spirochetes are abundant, the most direct method is visualizing the motile spirochetes directly using dark-field microscopy on fluid scraped from the chancre or Condylomata lata.
And blood tests.
Serology is the mainstay for later stages in screening. The VDRL test, or RPR, is positive in secondary and tertiary stages, but it's nonspecific and can yield false positives in other conditions like autoimmune diseases, particularly lupus, SLE. Therefore, any positive VDRL-RPR must be confirmed with more specific troponemal tests, like the FTA absorption test, FTA-ABS, or the MHATP.
And the treatment, thankfully, remains highly effective if administered promptly.
Yes, penicillin remains the absolute cornerstone of treatment. For early syphilis, primary, secondary, or early latent, a single intramuscular injection of 2.4 million units of long-acting benzathine penicillin G is usually curative.
What if it's later stage or unknown duration?
If it's latent syphilis, believed to be over a year's duration, or tertiary syphilis, the recommendation is typically 3 weekly injections of 2.4 million units each.
What about penicillin allergies?
For patients with a documented true penicillin allergy, alternatives like doxycycline, tetracycline, or sometimes erythromycin or azithromycin are used, but they generally require longer treatment courses and may be less effective, especially for neurosyphilis. Penicillin is strongly preferred if possible, sometimes requiring desensitization protocols.
Okay, next up, gonococcal vulvovaginitis gonorrhea, a highly efficient gram-negative diplococcus that specifically attacks columnar cells.
That's right. Neisseria gonorrhea specifically targets the columnar epithelium. In women, this is found lining the endocervix, the urethra, the ducts of the Skene's and Bartholin's glands, and, importantly, the fallopian tubes. It doesn't typically infect the squamous epithelium of the adult vagina.
And it's very contagious.
Extremely contagious. The transmission likelihood is high. Sources estimate women have about a 75% chance of contracting it from a single encounter with an infected male partner, whereas the risk for men from an infected female partner is lower, maybe around 35%.
What's the biggest challenge in controlling gonorrhea?
The greatest challenge is its often silent nature, particularly in women. Estimates suggest 50% to even 80% of infected women are entirely asymptomatic.
So they're unknowingly spreading it.
Exactly. They become efficient, unknowing reservoirs and spreaders of the disease within the community.
When symptoms do appear in women, what are the primary complaints? And what are the specific ascending complications we worry about?
Symptomatic women often complain of urinary issues first, like increased frequency or dysuria, painful urination because the urethra is commonly involved. They might also notice a purulent vaginal discharge originating from the cervix and see inflammation of the external genitalia or cervix on examination, cervicitis.
And if it ascends?
The late and potentially severe complications are primarily due to ascending infection. This includes pelvic inflammatory disease, PID, abscess formation in the Bartholin's glands, pyosalpinx, which is pus collecting in and distending the fallopian tubes, and ultimately infertility due to tubal scarring.
Is there a specific named syndrome associated with it?
Yes, a mastery detail is Fitzhugh-Curtis syndrome. This is a specific complication where ascending gonococcal or chlamydial infection spreads to the upper abdomen, causing inflammation around the liver capsule, perihepatitis. This leads to the formation of characteristic violin string adhesions, bands of fibrous tissue stretching between the anterior abdominal wall or diaphragm and the surface of the liver. It can cause sharp right upper quadrant abdominal pain.
Wow. How has diagnosis changed over time?
Diagnosis has dramatically shifted in recent years. While traditional methods like gram staining of cervical discharge looking for gram-negative intracellular diplocasia within neutrophils and culture on selective media like Thayer-Martin medium were the standard, they have limitations in sensitivity.
So what's used now?
The highly sensitive and specific nucleic acid amplification test, NAT, is now the favored approach, really the gold standard in most settings. NATs can be performed on endocervical swabs, vaginal swabs, or even urine samples, making collection easier. They boast sensitivities often exceeding 90% and have largely eliminated the need for routine culture for diagnosis, though culture is still important for tracking antibiotic resistance patterns.
Speaking of resistance, the management requires a dual therapy approach now, doesn't it?
Absolutely critical. Due to the emergence and spread of antibiotic-resistant strains of gonorrhea globally, single drug therapy is no longer recommended. To ensure effective treatment and also cover potential co-infection with chlamydia, which is very common, the current CDC standard, based on 2015 guidelines, though updates occur, mandates dual therapy. Ceftriaxone, 250 milligram, given intramuscularly in a single dose, plus azithromycin 1 gram, given orally in a single dose, both administered at the same time.
Why both?
The ceftriaxone provides highly effective treatment for gonorrhea, while the azithromycin provides additional coverage against gonorrhea, helping prevent resistance, and also effectively treats concurrent chlamydial infection. This dual approach is vital for comprehensive management and public health control.
Okay, now let's discuss chlamydial infection, often called the silent damager, which, as you just mentioned, often coexists with gonorrhea and is actually even more common.
Yes, Chlamydia trachomatis, specifically the non-LGV serotypes DK, is an obligate intracellular bacterium. It's the most commonly reported bacterial STI in many parts of the world, especially prevalent in young, sexually active women, typically under 25, but becomes rarer after age 40.
And its nickname, the silent damager, is really apt.
Extremely apt. Like gonorrhea, it's often asymptomatic, perhaps even more so. Estimates suggest up to 75% of infected females and 50% of infected males has no noticeable symptoms. The incubation period is typically around 8 to 11 days, maybe up to 3 weeks.
But despite the silence, the damage it causes, particularly to the reproductive organs, is disproportionately severe.
This is arguably the single most important clinical distinction we must emphasize for mastery. While chlamydia might cause only a mild vaginal discharge, cervicitis, or urethritis, if anything, its silent ascent up the reproductive tract can lead to severe salpingitis, inflammation of the fallopian tubes, and subsequent infertility.
More severe than gonorrhea.
Yes. Our sources clearly indicate, and clinical experience bears this out, that the tubal damage caused by chlamydia is often more insidious and ultimately more severe and destructive than the damage caused by gonococcus. It can lead to significant scarring, blockage, and long-term infertility or risk of ectopic pregnancy.
What about in males?
In males, it's the most common cause of non-gonococcal urethritis, NGU. It can also ascend to cause epididymitis, and there's growing evidence that chlamydial infection is known to alter sperm parameters, potentially causing DNA fragmentation and reduced motility, contributing to male factor infertility as well.
Does it cause that liver capsule inflammation too?
Yes. Like gonorrhea, chlamydia can also ascend to cause perihepatitis and the Fitzhugh-Curtis syndrome. It can also be associated with Reiter syndrome, or reactive arthritis, which is a triad of arthritis, urethritis, and conjunctivitis, sometimes with characteristic skin lesions.
Given its high prevalence and its very silent nature, accurate detection must be paramount.
Absolutely. This is why highly sensitive tests are crucial for screening and diagnosis. While older methods like immunofluorescence existed, the gold standard now, just like for gonorrhea, are the nucleic acid amplification tests, NATs. PCR and Lagos chain reactions performed on vaginal swabs, often self-collected, endocervical swabs or urine samples offer excellent sensitivity and specificity, often exceeding 96%.
And treatment, is it effective?
Yes. Thankfully, treatment for uncomplicated urogenital chlamydia is highly effective and relatively simple. The recommended regimens are typically single doses of azithromycin, 1 gram orally, or a 7-day course of doxycycline, 100 milligrams orally twice a day.
What about during pregnancy? Doxycycline is out, right?
Correct. Doxycycline is contraindicated in pregnancy. So the preferred alternative regimens during pregnancy are usually azithromycin, which is considered safe, or sometimes amoxicillin or erythromycin, although erythromycin often requires multiple daily doses and can have gastrointestinal side effects. Research into a vaccine is ongoing but challenging.
Okay. Let's move down the prevalence list now to trichomoniasis, the common protozoal vaginitis.
Right, trichomoniasis. This is an extremely common STD caused by Trichomonas vaginalis, which is an actively motile, flagellated, anaerobic protozoan parasite. It primarily affects women of childbearing age, but can occur at any age after puberty.
Transmission is mostly sexual.
Primarily sexual contact, yes. However, unlike many other STIs, Trichomonas can survive for a short period in moist environments. So transmission, though less common, can sometimes occur via shared fomites like damp towels, washcloths, or possibly contaminated bathing suits, especially when the vaginal pH is elevated, less acidic, such as during menstruation, which allows the protozoan to survive briefly outside the body.
Now, you mentioned earlier a visual feature that makes this diagnosis almost certain just on inspection.
Yes. While about 20% of women might be asymptomatic carriers, the classic clinical picture, when symptoms occur, is quite distinctive. It features a profuse, thin, often malodorous vaginal discharge that is typically described as creamy or yellowish-green and classically frothy or bubbly in appearance. That frothy nature is almost pathognomonic.
Anything else seen on examination?
Yes, upon speculum examination, the vaginal walls are often erythematous, red, and maybe tender. And the cervix might display multiple small punctate hemorrhagic spots, giving it an appearance often described as a strawberry cervix or colpetus macularis. This is highly suggestive, though not seen in all cases. Patients might also complain of significant vulvar itching, irritation, and sometimes urinary symptoms like dysuria or frequency due to associated urethritis.
How is it confirmed? Is it easy to diagnose?
Confirmation is usually quick and simple in a clinical setting. The gold standard is, crucially, the male sexual partner must be treated simultaneously, even if they are asymptomatic, which they often are. This is essential to prevent the ping-pong effect of reinfection back and forth between partners.
Any cautions with the medication?
Yes, metronidazole is generally avoided if possible during the first trimester of pregnancy due to theoretical concerns, although data on harm is limited. Also, patients should be advised to avoid alcohol during treatment and for at least 24-72 hours after the last dose due to the risk of a disulfiram-like reaction, nausea, vomiting, flushing.
Okay. Our final common vaginal infection is candidal or manilial vaginitis, the fungal or yeast infection. You mentioned this often tells us something about the patient's overall systemic health.
Yes, exactly. Vulvovaginal candidiasis, VVC, is caused by Candida species, most commonly Candida albicans, which is a yeast-like fungus, technically a gram-positive microorganism. It's important to know that Candida is actually part of the normal vaginal flora in about 25% of healthy, asymptomatic women. It usually only causes problems when there's an overgrowth, often because something has disrupted the normal vaginal environment or compromised the host's defenses. It tends to thrive in acidic environments, unlike BV or Trichomonas.
So we should look for underlying risk factors.
Absolutely. An episode of VDC, especially if it's recurrent or severe, should prompt clinicians to look for underlying predisposing factors. These commonly include immunosuppression, e.g. due to HIV infection or medications like corticosteroids, pregnancy due to hormonal changes, uncontrolled diabetes mellitus, high sugar levels promote yeast growth, recent use of broad-spectrum antibiotics, which kill off protective bacteria like lactobacilli, use of high estrogen oral contraceptives, and even factors like obesity or wearing tight, non-breathable clothing.
What's the cardinal symptom that really distinguishes Candida from the other common causes of vaginitis?
While other infections cause discharge and irritation, the absolute cardinal symptom of VVC is intense, pruritus vulvae unrelenting, often severe, vulvar itching. This is typically the most prominent complaint.
What else do patients experience?
This itching is usually accompanied by vaginal soreness, irritation, sometimes external dysuria, burning when urine touches the inflamed vulva, and dyspareunia, painful intercourse. The discharge is also characteristic, typically thick, white, clumpy, and often described as looking like cottage cheese, or sometimes flaky. It often adheres to the vaginal walls and doesn't usually have a strong odor, unlike BV or Trichomonas.
How is diagnosis confirmed? Is it also microscopic?
Yes, diagnosis is usually confirmed by microscopic examination of a vaginal smear. A sample of the discharge is mixed with a drop of 10% potassium hydroxide, KOH solution on a slide.
What does the KOH do?
The 10% KOH solution dissolves the epithelial cells and other cellular debris, making it much easier to visualize the characteristic fungal elements, the branching hyphae or pseudohyphae, and budding yeast spores under the microscope. Gram staining can also show the gram-positive yeast cells. Culture is usually reserved for recurrent cases or when non-albicans species are suspected.
And treatment. What are the options?
Treatment typically involves either topical intravaginal antifungal agents or oral antifungals. There are many effective topical options available over the counter or by prescription creams or suppositories containing azoles like miconazole, clotrimazole, tioconazole, etc., used for 1, 3, or 7 days depending on the formulation.
What about oral treatment?
For uncomplicated VVC, a single oral dose of fluconazole, 150 mg, is very effective, convenient, and often preferred by patients. For complicated or recurrent infections, defined as 4 or more episodes per year, longer courses of topical therapy or a prolonged weekly regimen of oral fluconazole for several months might be necessary to maintain control. It's also important to address any underlying predisposing factors if possible.
Okay. We now enter the deepest dive into Human Immunodeficiency Virus, or HIV. This is the ultimate systemic viral threat, the clinical end stage of which, if untreated, is acquired immunodeficiency syndrome, or AIDS, marking severe, irreversible immunosuppression and the onset of opportunistic diseases.
Yes, HIV. It emerged clinically in 1981. The virus itself was discovered in 1983. It's a small RNA retrovirus, primarily HIV-1 globally, though HIV-2 is prevalent in West Africa. The mechanism of infection is absolutely essential to understand for mastery.
How does it attack the immune system?
The virus specifically targets cells that express the CD4 receptor on their surface. Its primary target is the helper T lymphocyte, T cell, which is essentially the command and control center of the adaptive immune system. The virus uses the CD4 receptor, along with co-receptors like CCR5 or CXCR4, to gain entry into the T cell.
And once inside, what makes it a retrovirus?
Once inside, it uses a unique viral enzyme called reverse transcriptase to convert its RNA genome into double-stranded DNA. This is the retro step going from RNA back to DNA, the opposite of normal cellular transcription. This newly synthesized viral DNA is then transported into the host cell's nucleus and integrated into the host cell's own DNA by another viral enzyme, integrase.
So it becomes part of the host's genetic material.
Exactly. It integrates as a provirus. That provirus is now a permanent part of the host cell's genetic blueprint. It remains latent or gets transcribed whenever the host cell is activated, using the cell's own machinery to produce new viral RNA and proteins, effectively hijacking the immune cell to become an HIV factory. This ultimately leads to the destruction of CD4 T cells and progressive immune deficiency.
Let's clarify the transmission dynamics and that critical window period for testing that people hear about.
Transmission occurs primarily through 3 routes: sexual contact, both homo and heterosexual, parenteral exposure to infected blood or body fluids, like sharing infected needles among intravenous drug users, or accidental needle stick injuries, and perinatal transmission from an infected mother to her child.
What fluids transmit it?
The virus is present in significant concentrations in blood, semen, pre-seminal fluid, vaginal secretions, rectal fluids, and breast milk. Saliva, tears, and urine contain very low levels and are not considered routes for transmission unless visibly contaminated with blood.
Is transmission risk equal between sexes?
Our sources note that generally the risk of horizontal transmission per active intercourse from an infected male to an uninfected female, around 0.2% to 0.5% risk per act, though variable, is statistically higher than the risk from an infected female to an uninfected male, around 0.1% risk per act. Receptive anal intercourse carries the highest risk sexually.
Okay, and the window period?
Following initial exposure and infection, the body starts developing antibodies against the virus. This process, called seroconversion, typically takes about 2 to 3 weeks, sometimes up to 12 weeks, and rarely up to 6 months. The time between initial infection and when antibodies become detectable by standard tests is the window period.
Why is that period dangerous?
During this window period, the person is infected and highly infectious, often having a very high viral load, but standard antibody screening tests may still be falsely negative. This highlights the importance of understanding test limitations and considering repeat testing if exposure was recent. Modern combination tests that detect both antibodies and viral components, like the P24 antigen, can shorten this window significantly, often detecting infection within 2-3 weeks. Testing for the virus's genetic material, RNA or DNA, becomes positive even earlier, within days to weeks.
What does the long course of the disease look like without any medical intervention?
The natural history varies, but the median time from initial HIV infection to the development of clinical AIDS in the absence of treatment is tragically long, approximately 10 years.
What happens initially?
Initially, about 3 to 6 weeks after exposure, maybe 50–70% of people experience an acute retroviral syndrome. This presents with nonspecific symptoms: fever, fatigue, headache, sore throat, muscle aches, rash, cyclical lymph nodes, often resembling mononucleosis or the flu. This phase is often missed or misdiagnosed.
And after that?
This acute phase resolves spontaneously, followed by a long period of clinical latency. This is the asymptomatic phase, which can last for an average of 8 to 10 years. During this time, the person usually feels well, but the virus is continuously replicating, albeit at a lower level, and slowly destroying CD4 T cells, progressively damaging the immune system.
What are the specific illnesses that signal the immune system has finally collapsed into AIDS?
AIDS itself is defined by either a CD4 T cell count dropping below a critical threshold, 200 cells, or the occurrence of specific opportunistic infections, OIs, or cancers that take advantage of the severely weakened immune system.
Can you give examples of those AIDS-defining illnesses?
Common examples include pneumocystis jirovecii pneumonia, PCP, formerly known as pneumocystis carinii pneumonia, a type of fungal pneumonia, severe or recurrent bacterial pneumonia, tuberculosis, TB, which is a major co-epidemic with HIV globally, Kaposi sarcoma, a cancer causing purplish skin lesions, invasive cervical cancer in women, certain types of lymphoma, and opportunistic infections like cytomegalovirus, CMV retinitis, chronic cryptosporidiosis, or progressive multifocal leukoencephalopathy, PML, a brain disease.
What other clinical features might appear as the immune system weakens before full-blown AIDS?
As the CD4 count falls, patients may develop more generalized signs and symptoms: persistent generalized lymphadenopathy, swollen lymph nodes, unexplained fever or night sweats, significant unintentional weight loss, wasting, chronic diarrhea, persistent oral lesions like thrush, oral candidiasis, or painful aphthous ulcers, severe or recurrent outbreaks of herpes simplex or shingles, varicella zoster, conditions like thrombocytopenia, low platelets, and various neurological issues ranging from peripheral neuropathy to cognitive impairment, HIV-associated neurocognitive disorder, or HAND, potentially progressing to dementia.
Diagnosis and, perhaps more importantly, monitoring the progression of the disease rely entirely on two essential laboratory metrics, right?
Yes, absolutely. The diagnostic process usually starts with a screening test. Initial screening typically uses an enzyme-linked immunosorbent assay, ELISA, or a rapid antibody test, looking for antibodies against HIV core or envelope antigens, or combination tests looking for both antibody and P24 antigen.
And confirmation.
Critically, all positive initial screening tests must be confirmed with a more specific supplemental test, traditionally the Western blot, or now more commonly, a specific HIV-1 HIV-2 antibody differentiation assay or HIV RNA testing to rule out any possibility of a false positive result.
Okay, that's diagnosis. What about monitoring?
For monitoring the clinical progress of the infection, assessing immune function, and guiding treatment decisions, we rely heavily on two key laboratory markers: the CD4 T cell count and the HIV viral load, measuring the amount of HIV RNA in the blood.
Let's define those CD4 count thresholds again. They're essentially the immune system's internal scorecard telling us how damaged it is.
Exactly. They provide a snapshot of the immune system's health. A CD4 count greater than 500 cells per milliliter generally indicates no significant immunosuppression. The immune system is relatively healthy.
What about lower counts?
A count between 200 and 500 cells per milliliter indicates moderate immune damage. Symptoms are more likely to appear in this range, and therapeutic intervention, starting antiretroviral therapy, RT, is strongly recommended.
And the critical danger zone.
The critical threshold is a CD4 count less than 200 cells per milliliter. This signifies severe immunosuppression and officially meets the definition for AIDS in the U.S. and many other places, regardless of whether the person has had an opportunistic illness. The risk of developing life-threatening opportunistic infections increases dramatically below this level. Patients in this range often present with symptoms like oral thrush, unexplained fever, fatigue, and weight loss.
Antiretroviral therapy, RT, fundamentally changed the prognosis of this disease from a death sentence to a manageable chronic condition. How does it work?
It absolutely did. RT has been revolutionary. These drugs don't cure HIV, but they work by inhibiting key enzymes or steps in the virus's replication cycle, drastically suppressing the amount of virus in the body. For example, the earliest class, nucleoside-nucleotide reverse transcriptase inhibitors, NRTIs like zidovudine, AZT, or tenofovir, block the reverse transcriptase enzyme, preventing the conversion of viral RNA to DNA. Non-nucleoside reverse transcriptase inhibitors, NNRTIs, like efavirenz, also target reverse transcriptase, but in a different way.
Are there other classes of drugs?
Yes, several other classes target different steps. Protease inhibitors, PIs, like ritonavir or darunavir, block the protease enzyme, which is needed to assemble new functional virus particles. Integrase inhibitors in STIs, like raltegravir or dolutegravir, prevent the viral DNA from being integrated into the host cell's DNA. And there are also entry inhibitors that block the virus from entering the CD4 cell in the first place.
What's the standard approach today? Using just one drug?
No, the standard today is combination therapy, often referred to as highly active antiretroviral therapy, or HAART, though the term ART is now more commonly used. This involves using a cocktail of 3 or more antiretroviral drugs, typically from at least 2 different classes, taken together daily.
Why multiple drugs?
Using multiple drugs that attack the virus at different points in its life cycle is much more effective at suppressing viral replication and, crucially, helps prevent the development of drug-resistant strains of HIV. This combination therapy can reduce the viral load to undetectable levels in the blood and allow the CD4 count to recover, significantly improving health and longevity.
Now, the management of HIV during pregnancy presents a unique mastery challenge. The goal isn't just maternal health, but also preventing vertical transmission to the infant.
Yes, this is a critical area where ART has had a profound impact. If the mother is untreated, the risk of perinatal transmission passing HIV to the baby during pregnancy, labor, delivery, or breastfeeding is quite high, ranging from 20% to 30%, sometimes even higher in some populations.
Where does transmission happen most often?
Transmission can occur transplacentally across the placenta during pregnancy, through breastfeeding postpartum, or most commonly intrapartum, during the process of labor and delivery due to exposure to infected maternal blood and vaginal fluids.
So the prevention strategy must be aggressive and multi-pronged.
Absolutely. The cornerstone of prevention of mother-to-child transmission, PMTCT, is ensuring the pregnant woman is on effective ART herself, aiming to achieve an undetectable viral load well before delivery.
How does the method of delivery play a role in prevention?
Elective cesarean section, performed before the onset of labor and rupture of membranes, can be a crucial tool, especially if the mother's viral load is not fully suppressed, for example, over 1,000 copies per ml, near the time of delivery. The goal is to minimize the baby's contact with the infected maternal fluids during passage through the birth canal. However, if the mother's viral load is consistently undetectable on RET, the additional benefit of C-section is much smaller, and vaginal delivery may be considered safe.
What about medication timing during pregnancy? You mentioned zidovudine earlier, but also a caution.
Right. Historically, zidovudine AZT monotherapy was used, often initiated around 14-16 weeks, if the mother needed treatment for her own health. However, we noted the mastery detail. There were concerns about potential teratogenicity, specifically neural tube defects, if used in the very first trimester. But the guidelines have evolved significantly. The current recommendation in most resource-rich settings, and increasingly reflected in WHO guidelines, is for all pregnant women diagnosed with HIV to start a combination ART regimen as soon as possible, regardless of their CD4 count or viral load, and continue it lifelong.
What kind of regimen?
Often a preferred regimen includes 2 NRTIs plus an integrase inhibitor, like dolutegravir, which is highly effective and well tolerated. For example, a common combination might be tenofovir disoproxil, fumarate emtricitabine, or lemivudine, plus dolutegravir. This comprehensive approach ensures maximal viral suppression for both maternal health and PMTCT.
And once the baby is born, does the prophylaxis continue for the infant?
Yes. Even with effective maternal RT, the newborn receives antiretroviral prophylaxis for a period after birth to further reduce any residual risk. The specific regimen and duration depend on the estimated transmission risk, based on maternal viral load, adherence, etc. For low-risk infants, this might just be 4 to 6 weeks of zidovudine syrup. For higher-risk situations, combination prophylaxis with multiple drugs might be used.
What about that nevirapine dose you mentioned?
Single-dose nevirapine given to the mother during labor and a single dose to the newborn shortly after birth was a simpler, older strategy used particularly in resource-limited settings. It was shown to reduce transmission risk by about 50% compared to no intervention, but it's less effective than maternal combination RT and carries a risk of resistance. It's generally been superseded by more effective strategies where feasible. Overall, with effective maternal RT and neonatal prophylaxis, the risk of vertical transmission can be dramatically reduced from 20–30% down to less than 1%, sometimes even less than 0.5%, Truly remarkable progress.
Finally, the difficult question of lactation or breastfeeding. What's the guidance?
This remains a complex issue, with differing guidance depending on the setting. In resource-rich countries like the US or in Europe, where safe alternatives like formula feeding are readily available and affordable, avoiding breastfeeding entirely is strongly recommended for HIV-positive mothers. This completely eliminates the risk of postnatal transmission through breast milk.
But that's not always feasible elsewhere.
Exactly. In resource-poor countries where access to clean water for mixing formula is limited, formula is expensive, and the risks of infant mortality from diarrhea or malnutrition due to unsafe formula feeding might outweigh the risk of HIV transmission, the guidance shifts. The WHO currently advises that HIV-positive mothers in these settings who are fully adherent to ART with suppressed viral load should practice exclusive breastfeeding for the first 6 months of life.
Why exclusive? What about mixed feeding?
This is a critical point. The sources note that mixed feeding giving both breast milk and other foods or liquids, including formula or water, before 6 months significantly increases the risk of HIV transmission compared to exclusive breastfeeding. The theory is that the other substances might damage the infant's delicate gut mucosa, making it easier for the virus in breast milk to enter the baby's system. So it's either exclusive breastfeeding with maternal RT or exclusive formula feeding mixing is the worst option in terms of transmission risk.
Okay. That brings us towards our synthesis, really tying together the profound impact of these STIs, especially on infertility, looking at the shifting practical management protocols, and thinking about comprehensive prophylaxis.
Right. And the global scale of STI-related infertility is just staggering. WHO estimates suggest almost 90 million cases of infertility worldwide each year might be attributable to STIs, with the highest prevalence tragically found in sub-Saharan Africa.
Which organisms are the main culprits for infertility?
The key organisms driving this crisis are undoubtedly Gonococcus, Neisseria gonorrhea, and Chlamydia trachomatis. These are the primary causes of PID in women, leading to tubal scarring and blockage. The sources also highlight Mycoplasma genitalium as an increasingly recognized significant causal agent of PID and potential infertility, though it's historically been harder to detect.
Can you break down the specific mechanisms of infertility, maybe differentiating the damage in males versus females?
Sure. In males, untreated gonorrhea infection is a classic cause. It typically starts as urethritis, but can ascend to cause inflammation of the epididymis, epididymitis, and testes or chitis. This inflammation can lead to scarring and blockage of the ducts that transport sperm. The stats are sobering. Unilateral epididymoorchitis from gonorrhea can cause infertility in about 25% of affected men, and if it's bilateral, the infertility rate jumps to around 40%. Chlamydia can also cause epididymitis in men.
And in females, it's mainly PID.
Yes. In females, the primary mechanism is pelvic inflammatory disease, PID, resulting from ascending infection from the cervix. Both gonorrhea and chlamydia are major causes. The inflammation and subsequent scarring within the fallopian tubes can lead to complete blockage, preventing the egg and sperm from meeting, or partial blockage, which dramatically increases the risk of a dangerous ectopic pregnancy.
And you stressed chlamydia's impact.
Yes, we must re-emphasize that key takeaway. Chlamydia, often being the silent damager, frequently inflicts more severe and permanent tubal damage than gonococcus, partly because it can persist longer without causing acute symptoms, allowing chronic inflammation and scarring to develop unnoticed. And Mycoplasma genitalium, which is often difficult to culture, taking weeks or months, is now more readily detected by PCR and is confirmed as another important cause of cervicitis and PID, contributing to the infertility burden.
Okay. Now, given the sheer volume of common vaginal infections like BV, Candida, and Trichomonas, and the real-world constraints of time and cost in busy clinics, the clinical world adopted a pragmatic strategy called the syndromic approach to management. Can you explain that?
Yes, the syndromic approach was developed largely by organizations like the WHO, particularly for use in resource-limited settings. But its principles are sometimes applied elsewhere too. The rationale is that traditional diagnostic tests like microscopy or cultures can be time-consuming, require laboratory infrastructure that might not be available, are costly, and critically, patients in high-risk or transient populations often don't return for their results and follow-up treatment.
So what does syndromic management actually involve?
It involves treating patients based on the clinical syndrome they present, with a collection of symptoms and signs, rather than waiting for a specific laboratory diagnosis. Based on flowcharts or algorithms that consider the most common causes of a particular syndrome, like vaginal discharge or genital ulcer, in that population, The patient is given single-sitting, broad-spectrum, multiple drug therapy designed to cover the most likely pathogens.
Can you give an example for vaginal discharge?
Sure. If a woman presents with symptoms of vaginal discharge, following a simple algorithm, which might check for specific features like odor or vulvar itching, she might receive a prepackaged cocktail of medications intended to treat the big three causes simultaneously. For instance, she might be given azithromycin 1 gram for chlamydia, maybe gonorrhea, metronidazole 2 grams for trichomonas and bacterial vaginosis, and fluconazole 150 milligrams for candidiasis, all taken at once.
That certainly sounds incredibly efficient. One visit, treatment started immediately. But what's the inherent clinical trade-off or disadvantage?
The advantage is clear: convenience, cost-effectiveness in terms of avoiding expensive tests, and quicker treatment initiation, which hopefully reduces symptoms faster and curbs community spread. The massive disadvantage, however, is the lack of precision.
Meaning overtreatment.
Exactly. The patient inevitably receives unnecessary multiple therapies if only one organism, or maybe none, was actually causing the problem. This exposes her to the potential side effects of drugs she didn't need. More broadly, from a public health perspective, this blanket approach contributes significantly to the problem of overprescription of antibiotics and antifungals.
And the concern there is resistance.
Yes, it fuels the potential emergence and spread of drug resistance, particularly antibiotic resistance, which is a major global health threat. So while syndromic management has its place, especially where diagnostic capacity is limited, it's recognized as a compromise that potentially undermines efforts towards more targeted therapy and antimicrobial stewardship. It's a real tension.
Before we get to our final takeaways, we absolutely must touch on hepatitis B virus, HBV, as it's intrinsically linked to STIs and shares transmission routes.
Yes, HBV is a DNA virus, unlike HIV, which is RNA. It is efficiently transmitted sexually, as well as parenterally, blood, and perinatally. It's particularly important in context of STIs because a sexual partner may be an asymptomatic chronic carrier, capable of transmitting the virus for years without knowing it. This carrier state is especially common in individuals who are also infected with HIV. Chronic HBV infection can lead to serious liver disease, including cirrhosis and liver cancer.
But the good news is we have excellent prevention.
Yes, the really good news about hepatitis B is that we have a highly effective and safe prevention tool: prophylactic vaccination. The standard hepatitis B vaccine series, usually given as 3 intramuscular injections, typically at 0, 1, and 6 months, provides long-lasting, often lifelong immunity for most people. Vaccination is recommended for all infants, adolescents, and adults at risk, including anyone being evaluated for STIs.
Okay. Finally, let's talk about prophylaxis and contraception, specifically for women managing STIs or at high risk.
Right. For preventing acquisition or transmission of STIs during intercourse, barrier methods are essential. Male latex condoms, used correctly and consistently, are highly effective at preventing the transmission of most bacterial and viral STIs, including HIV. Female condoms also offer protection.
What about other barrier methods?
Simpler barrier methods like the female diaphragm or cervical cap offer some protection against cervical infections like gonorrhea and chlamydia, and possibly against pregnancy. But they are insufficient for preventing infections transmitted via skin-to-skin contact, like herpes, HPV, syphilis, as they leave the vulva and perineum exposed. Spermicides alone are not recommended for STI prevention and may even increase risk by irritating tissues.
So what's the ideal approach for someone needing both pregnancy and STI prevention?
We strongly advocate for dual contraception, or perhaps more accurately, dual protection. This means using a barrier method, primarily condoms, for infection protection every time, combined with a more reliable method for pregnancy prevention, such as hormonal contraceptives, pills, patches, rings, injections, implants, or an intrauterine device, IUD, or surgical sterilization if desired.
Are there specific contraceptive rules or considerations for women living with HIV?
Yes, there are crucial considerations. An intrauterine contraceptive device, IUCD, either copper or hormonal, can be a suitable option for HIV-positive women, but only if they are clinically stable and consistently adherent to their ART with good immune function. If a woman is not on therapy, has advanced HIV disease, or has active STDs, inserting an IUCD significantly increases her risk of developing pelvic inflammatory disease.
What about hormonal methods and ART?
This is another key interaction. Certain antiretroviral drugs, particularly some protease inhibitors and NRTIs, are known to interact with hormonal contraceptives metabolized by the liver. They can potentially reduce the bioavailability and effectiveness of estrogen and progestin components in pills, patches, or rings, possibly leading to contraceptive failure. Therefore, counseling on potential drug interactions and considering methods less affected by RT, like injectables, implants, or IUDs, or emphasizing consistent condom use, is essential for HIV-positive women using hormonal contraception.
And a final quick note on managing STDs, specifically in adolescents, where we know incidence rates for some infections are rising sharply.
Yes, this is a major public health challenge. The rise in STIs among adolescents and young adults is often linked to factors like earlier initiation of sexual activity, increased number of partners, social networking facilitating casual encounters, inconsistent condom use, and sometimes substance use influencing decision-making. We see particular increase in chlamydial infections and also venereal warts, HPV, in this age group.
How should the clinical approach differ for adolescents?
A key consideration is the often high unreliability of follow-up in this population. Therefore, clinicians are strongly advised whenever possible to utilize diagnostic tests that can provide rapid results, like point-of-care tests if available, and to use effective on-site single-dose antibiotic regimens for infections like gonorrhea, chlamydia, and trichomoniasis, ensuring treatment is completed before the patient leaves the clinic.
And using the visit for education.
Absolutely critical. Every clinical encounter with an adolescent, regardless of the reason for the visit, must be leveraged as a mandatory opportunity for confidential, non-judgmental education about sexual health, risk reduction strategies, consistent condom use, and offering necessary immunizations, especially the HPV vaccine series. Building trust and providing accessible services are key.
Okay. That provides us with a really comprehensive clinical mastery of the entire spectrum, all the way from parasites like lice and scabies, through bacterial ulcers and vaginitis, up to the major viral threats like HPV, herpes, and the systemic retrovirus, HIV. As we conclude this deep dive, what are the 3 or 4 most essential takeaways the listener absolutely must internalize from all this?
All right, let's boil it down. First, the profound cancer risk associated with high-risk HPV, type 16, 18, and others, cannot be overstated. These infections must be identified through screening, treated appropriately if abnormal cells develop, and followed up vigilantly. The HPV vaccine is our best primary prevention tool here. Get it before exposure.
Okay, HPV and cancer link plus vaccine. What's second?
Second, the devastating impact on fertility. Gonoccoccal and chlamydial infections are the primary drivers of PID and subsequent infertility. But critically, remember that chlamydia, often being silent, tends to inflict more severe and permanent tubal damage. Early detection and treatment are vital to preserve fertility.
Got it. Chlamydia is silent damage.
Third, syphilis is not just a genital ulcer. It's a systemic disease, the great mimicker, that can lead to catastrophic neurological and cardiovascular damage years down the line if untreated. Immediate diagnosis and adequate treatment with penicillin are absolutely non-negotiable to prevent these long-term sequelae. Don't miss it.
Penicillin for syphilis. And fourth,
the power of treatment for HIV. While not a cure, highly active antiretroviral therapy, HAART or ART, is revolutionary. It transforms HIV into a manageable chronic condition, and crucially in this context, it drastically reduces the risk of vertical transmission from mother to child from potentially 30% or higher down to 1% or even less. Treatment is prevention.
So summarizing, HPV, cancer risk and vaccine, chlamydia's severe silent damage and infertility, syphilis systemic threat needing penicillin, and HAART's power for HIV management and prevention. Very clear.
And maybe a quick addendum. For women living with HIV, regular Pap smears are even more crucial due to the increased risk of HPV persistence and cervical cancer, and dual protection, condoms plus another reliable contraceptive, is strongly advised.
Excellent points. Now, we've spent this entire session emphasizing the need for precision, understanding the specific mechanisms of viruses like herpes that we can't eradicate, recognizing the devastating consequences of silent damagers like chlamydia, and appreciating the systemic, multi-stage threat of pathogens like syphilis and HIV, which demand specific tailored treatments. But we also acknowledge the practical public health shift towards convenience, especially in high-volume, low-resource settings through the use of single-dose, broad-spectrum syndromic management.
But pragmatic approach.
Given the known limitations of that approach, the overtreatment, the exposure to unnecessary side effects, and particularly the implication of contributing to the global crisis of antibiotic resistance, how do we, as clinicians and public health professionals, reconcile the undeniable convenience and immediate treatment access offered by syndromic management with the fundamental goal of clinical mastery? Mastery demands precision diagnosis, targeted therapy, and definitive long-term public health control.
That's the tension, isn't it?
Exactly. Are we, in some situations, inadvertently trading short-term gains and treating symptoms quickly for potential long-term failures and truly controlling these infections and preserving antimicrobial efficacy for the future? That inherent tension between the speed and pragmatism of syndromic care versus the precision required for true mastery and eradication, that's the essential question we leave you, our listener, to explore.